and Dr. Hill today he will talking about one subject I think is quite interesting is herpes simplex keratitis, and even he looking in the ultrasound department, but he talking about keratitis is one easy very common in the cornea department. And I think the idea is very good because when he looking in other department, but he talking about other disease in other department, very good for you and very good for everybody because we can have a some more knowledge in every department. And as you know, now population in the world is more than 50% the people have got herpes simplex. So that means many patients have herpes simplex keratitis in our hospital. And this subject today is quite interesting, and we are looking for your talking, please.
So good afternoon, everyone. Before going to our main topic, I would like to introduce two clinical cases in the outpatient department. The first case is female patient, 50 years old. She complained about her redness and discomforting on her left eye, and she also had herpes simplex virus keratitis 5 times in 3 years. On examination, we found the corneal stroma edemas with the vascularization and also scar. Her VA on the right eye is 20/160, and on the left eye is counting fingers 0.2 meters. She was diagnosed with HFV stromal keratitis and was given oral cyclovir 800 milligrams 3 times a day, with the conjunction of topical corticosteroid 4 times a day, and also the acyclovir ointment 5 times a day. So after 10 days, all the symptoms were relieved. As you can see on the screen, the stromal edemas is reduced. Her VAs on the left eye got better to counting finger 0.5 meters, but the problem here is that after that she did not come for recheck. The second case is male patient, 42 years old. He also complained about the blurry vision and foreign body sensation on his right eye. He has ocular history of the 2 times dendritic keratitis in 2 years. And his visual acuity on the right eye is bad. It's only 20/400, and he was diagnosed with AHP dendritic keratitis, and also given the treatment of oral acyclovir with topical corticosteroid and cycloplegic. And this, like the first case, the patient did not show up after the first examination. So you can notice that the common things of these two clinical cases are the patient already gave up their treatment very soon, and they also have the high rate of recurrence. These are also the challenges in the herpes simplex virus treatment, which is the reason why I present for my present today. Here's the content of my presentation. The definition of HSV keratitis is very simple. This disease is an infectious disease of cornea caused by herpes simplex virus, and until now, the humans are the only known reservoirs of this virus. Many studies have been made, and they show the high rate of latent HSV in human transgender ganglia. So as you can see on the screen, the rate here is quite high, 90%. And especially in one study, they saw that there's 100% patients are found with HSV virus in their ganglia. Two common types of HSV is HSV1 and HSV2, and the type that causes the keratitis is HSV1. You can see on the screen, this virus can cause many diseases in different parts of our body. Here is a cycle of the transmission and recurrence. The virus can be transmitted through the skin lesions or the direct secretion, for example, the patient with saliva or tears. After the primary infection, the virus is spread through the sensorineural axon to the trigeminal ganglia, where they stay there until they meet the reaction factors. Then this virus will replicate and then come out through the axon to the peripheral and cause disease. So many studies show that the recurrent rate is quite high. In hepatic eye disease study, after the first year, the rate is 32%, and in another study, after 20 years, this rate is surprisingly high, of 60%. One small fact is that the higher the number of previous stacks, the greater the risk of the recurrence. Data also shown that the stromal keratitis have the highest proportion of recurrence, followed by the epithelial and then endothelial ones. Many studies have been made to show that there are relationship between the trigeminal ganglion reactivation and the HSV epithelial reactivation. However, the relationship between this reactivation and the HSV stromal and endothelial reactivation is still unclear. Coming to the classification is very important because the different corneal layers affected by the HSV keratitis is a different mechanism. For example, the HSV epithelial keratitis is caused by the direct infection of the virus to the epithelium. Meanwhile, the stromal keratitis is caused by both the direct infection and the immune mechanisms. That is why the epithelial keratitis is treated with the antiviral agent only, and the stromal keratitis is treated with the combination of corticosteroid and antiviral agent. So for the corneal layer of epitheliums, the nomenclature for the HSV keratitis is HSV epithelial keratitis, and for the stromal, there are two subtypes: is HSV stromal keratitis without ulceration or with ulceration. The other name of the endothelial keratitis is iciform keratitis. I will now talk about the disease modifier which can affect our choice of treatment later. So the first factor is the general susceptibility of the host. So any condition that increases cell-mediated immunity may increase the risk of HSV infection. So the patient who have this condition will experience more severe disease, especially these four types of patients. The first type is the patient with organ transplants, because these patients are often given corticosteroid or other immune suppressant medication, which is weaken their immunity. The other group is the patient who have long-standing diabetes, because it's believed that this patient have impairment of the cell-mediated immunity. Another group is that the patient with the measles infection, because the measles virus will damage the T cell and then affect the patient's immunity. And last but not least, the patient with HIV/AIDS. The patient will require longer treatment, and but they have the same type of skin type of lesion. Another factor that affects the disease is age. In children, in comparison with the adults, they often have the bilateral disease with more severe keratitis and high recurrent rate. Besides, the examination in the children is quite difficult. That's why the HSV keratitis in the children are commonly misdiagnosed, and the immune response in the children is quite strong. That is why the children are more likely to develop scarring, which causes the amblyopia rate. That's why the treatment in children require closer and more frequent monitoring. In atopic patients, these patients are more likely to have the bilateral disease, and they have less response to topical antiviral agent than with the oral agents. So that's why they have more severe keratitis with subsequent complications. Many immune structures have improved the trigger of orophages or genital HSV as well as labial HSV, such as fever, menstruation, or UV exposure. There are not enough evidence of the relationship between this immune stressor and the activation of ocular HSV disease. We now coming to the medication which affect the disease. The first drug I would like to mention is the prostaglandin analogs. These drugs are commonly used in glaucoma and is mediate inflammation and result in the activation of the viral transmission factors. There are studies about the retinoblast which cause the epithelial HSV epithelial keratitis. So they suggest that we should avoid topical prostaglandin in the patient with history of HSV. Corticosteroids are widely used in our practice, and the drugs affect every aspect of immune response, which can affect the infection and the severity of the disease. Besides, the research in the cell culture models show that these drugs appear to have direct effect on the reactivation of the latent virus, which can cause the recurrence. And finally, the use of topical steroid on the patient with HSV stromal keratitis can result in severe HSV epithelial keratitis. The final drug I want to mention today is the angiogenesis inhibitors. Although this statement is quite controversial, the relationship between these drugs and the disease remain unclear, because also despite of the use of this drug to treat the corneal vascularization. But however, there was one case reported which HSV epithelials appeared just 3 days after the first injection of bevacizumab. Another condition that affects the disease is contact lens wear. However, there are many studies have been made that the result is conflict. And in head study, there's no association between the contact lens wear and the recurrence of HSV keratitis. The statement of laser surgery induced the HSV keratitis is quite unclear. The possible reason for this statement is that this surgery caused the focal laser trauma to the corneal nerve or the cornea itself, and the direct activating of laser light as well as the post-operative use of corticosteroid. Other surgery, such as the cataract surgery or the penetrating or lamellar keratoplasty, can induce HSV keratitis due to its trauma from the surgery and the post-operative use of corticosteroid. So they suggest that antiviral processes should be used in patients with a history of HSV ocular disease. I will now go through the diagnosis of this disease. The patient which have HSV epithelial keratitis can have the swollen opaque epithelial cells arranged in the stellar pattern like this, or they may have dendritic ulcers or geographic ulcers. This patient also experiences reduced corneal sensation and associated sites such as follicular conjunctivitis or the skin lesions. In healing process, there may be context epithelial erosions or irregular epithelium like this, or mild subepithelial haze like this. In stromal keratitis, patients may have the unifocal or multifocal haze without the ulcers, and reduced corneal sensation in the non-necrotizing keratitis, or in the necrotizing keratitis, patient may have stromal necrosis and meltdown like this, and this disease progresses rapidly. In the endothelial keratitis, patient may have the stromal epithelial in a round or oval shape like this, and they may have both in basement membrane or Wesley immune ring. Here are the criteria for the outcome of the treatment suggested by the guideline of Massachusetts R&E Hospital established in 2014. There are 5 criteria. The first criteria is resolution of the corneal infection. The second one is reduction in pain. The third one is minimization of corneal scar and neovascularization. The fourth one is prevention of the corneal perforation, and the last one is the restoration of visual function. These 5 outcome criteria is quite general and not going into the detail. So here's the drugs which is approved by the FDA, and in Vietnam there's the acyclovir ointment and the oral acyclovir are the only one available and widely used. Acyclovir ointment is very familiar to us. It can be used in the children with the age of 2 or older. It is classified as a pregnancy category type B, which means we can use in the pregnant patient, but with consideration. The ocular toxicity includes the superficial punctate keratopathy or follicular conjunctivitis or the lacrimal contour obstruction, and of course the allergic reaction. The time of the occurrence of this toxicity may be just 21 days according to the guideline. Coming to the oral acyclovir, the dose is different between patients, and this also can be used in children and pregnant mothers. The toxicity is found in the intravenous injection and also the overuse of maybe 100 tablets. In high concentration, this drug produces the crystal in the urine and cause neuropathy. Here the protocol suggested by this guideline: in the patient with epithelial keratitis, we should use the therapeutic dose, topical or oral anti-agent. This guideline suggests that we use the acyclovir ointment 5 times a day every 4 hours, or we use oral acyclovir with a dose on the board. Study also suggests that there's no evidence to support the use of 2 antiviral agents which can faster the healing. In the patient with epithelial keratitis, we should avoid use the topical steroid, and topical interferon may be another choice, but it's not approved by the FDA. So the regimen, it can be used, it can be performed in the slit lamp, and its purpose is to protect the adjacent healthy epithelium from infection and eliminate the stimulant to stromal inflammation. In this technique, the epithelium should be removed 2 millimeters beyond the edge of the ulcers, and it should not be used alone. It should be used with the antiviral agent. Here's a protocol for the HFP stromal keratitis without the ulceration. We should use the therapeutic dose of the topical steroid and prophylactic dose of oral antiviral. The duration of the treatment is quite long. It's suggested to use greater than 10 weeks of corticosteroid plus the acyclovir 400 mg twice daily. And the lower the corticosteroid dose, the longer the interval between the subsequent dose reduction. Although there's results show that the using of 2 antiviral agents is faster than using 1 agent alone, but this result have no statistical meanings, and topical cyclosporine might be replaced or reduce the need of the topical steroid in patients with both HSV stromal keratitis and the steroid-induced glaucoma. In the patient with stromal keratitis with the ulceration, we should use a limited dose of topical steroid plus the therapeutic dose of the oral antiviral. So they suggest that we use the prednisolone 1% twice daily plus the acyclovir 800 mg 3 to 5 times daily. And this dose is reduced to prophylactic dose after the epithelium is healed, and the topical steroid should be tapered slowly. In the patient with endothelial keratitis, we should use the therapeutic dose of topical steroid plus the therapeutic dose of oral antivirals. Instead, we use the corticosteroid 6 to 8 times daily plus acyclovir 3 to 5 times daily. And this use of the oral antivirals should be reduced to prophylactic dose after 7 to 10 days. However, there's still the situation when the choice of topical antiviral agent and the orals is quite difficult, and this guideline will help us to choose. We suggest that the topical antiviral agent should be used in the patient with renal impairment or the elderly patient with renal disease. The topical antiviral agent should be used in the pregnant patient and also the nursing mother. The oral antiviral agent should be used in patients who are physically unable to use gel or drop or the contact lens wearers. It should be used in children who cannot use a topical agent, and also should be used in the patient that require lengthy treatment of antiviral agent, maybe more than 21 days. The patient with pre-existing ocular surface disease such as dry eye or patient who needs a prophylactic treatment should be given the oral antiviral agent also. The prophylactic dose should be recommended for the patient with a history of recurrent HIV stromal keratitis, because this type disease is the main cause of the visual impairment of this disease, and the dose is 400 mg twice daily for at least 1 year or greater. We should educate the patient to avoid and correct the predisposing factor as we mentioned in the disease modifier. There is HIV vaccine, but it is not approved by FDA. However, their research shows that the HIV-1 vaccines might have reduced the number of duration of the ocular disease, but it needs to be studied furthermore. In conclusion, the hepatitis virus is a common cause of corneal disease. The patient will have potential of recurrence after treatment. The treatment is, of course, require adjustment depending on the clinical cost, and the prophylaxis is necessary in the patient with a history of stromal keratitis. Thank you for listening.
Thank you very much, Dr. Hill, for your presentation. And as you know, the herpes simplex hepatitis, the population lost many observations in clinic, and also the doctor can see the patient every day. And as information for treatment herpes keratitis, the Shishlopthai already used for the patient. And for the new information here, I just see your presentation. Is when the patient have a cornea